So we'll start with the middle there.
So this is Dan Carr, Tufts University. I think these are all fabulous presentations and appreciate that the scope of what's being covered is so broad that not everything can be squeezed in a workshop. Having said that, and just considering this workshop may have impact on policymakers, I just wanted to insert a couple of placeholders or post-its. One is that we aren't hearing much about cancer pain, and if one interprets the remit of the conference literally, it was not restricted to chronic non-cancer pain, even though we've seen that as a huge public health problem. So I think the relevance of these modalities, some of which have been trialed in cancer pain, should be kept on the table. The other category is acute pain. There's, as everyone knows, tremendous interest in the mechanisms by which acute pain becomes chronic. And there are a number of trials going back at least 40 or 50 years of non-pharmacologic modalities, such as simply providing patients with information about what's going to happen to them during the operation, that were found in randomized controlled trials to be effective, both for pain intensity and morphine consumption. Beth Darnell was here, and she's published on the behavioral approaches to acute pain through her program on My Surgical Success. And that notion of a dimming or receding of the boundaries between acute pain and chronic pain is further evident in recent publications, according to which the old focus in clinical pathway design was on the procedure exclusively, and that's being balanced, if not supplanted, by a focus upon patient factors, such that the activities of acute pain services are deployed towards high-risk patients selectively and better meet their needs for what has been termed a soft landing postoperatively. So these are just some placeholders, more in the nature of general comments. Thank you.
Thank you. We'll go to Lynn.
Thanks for two great presentations. Lynn DeBar, Kaiser Permanente, Washington Research Institute in Seattle. So just a quick question about sham PT. I just wondered if you could explain what that is.
That's what I do every morning.
Sure. So in our trial, which is looking at people with shoulder pain, we have people receiving equal amounts of therapy time. It's just that some of the therapy is obviously focusing on the shoulder pain, but then the sham therapy, they're doing other things with the therapist that's not aimed to improve their shoulder pain. For stroke survivors, we're working on gait issues, pre-gait issues, transfers, or maybe some other functional tasks. So they say, well, this is therapy. I understand I'm getting therapy. Whether or not they say, well, it's not directed at my shoulder, that's harder to understand. We are inquiring about what they think they've got, but that's how we do it. So we really try to maximize or equalize the time they have together to control for that therapeutic aspect of being with their provider.
Hi, Nancy Baker from Tufts University. I have more of a comment than a question. I've sat through all the programs today, and I've heard lots of discussions of different types of non-pharmacological therapy, chiropractic, acupuncture, but not a single person has mentioned occupational therapy as a treatment for chronic pain. And I just wanted to, talking about placeholders, I wanted to put occupational therapy on the table as an important aspect of chronic pain treatment, because we are trained not only in the biomechanistic treatment of chronic pain, but we're also trained in the psychosocial aspects of treating people with chronic pain. We can do cognitive behavioral therapy, we can do environmental modification, and our primary outcome is and always has been function, and how to get people back to doing what they did before, which I hear is a very important outcome from what everybody's talking. So I just want to make sure that occupational therapy is considered in this mix, as well as all the other important non-pharmacological treatments.
Thank you.
I just wanted to clarify something. A number of speakers today have commented on the fact that pretty much every treatment that's not ineffective or unknown effectiveness has a small effect, be it pharmacologic or non-pharmacologic. But I think we often lose sight of what does that mean. What it doesn't mean is that every person that gets that benefits a small amount. This is an average. And in fact, if you look at what's called responder analyses, where you look at what fraction of people with a treatment or the comparator actually have clinically meaningful amounts of improvement. And then you compare that, what you find is that in a slide actually that Linda Barr showed that of studies that Karen Sherman and I did, we found generally that 60% getting the CAM treatment usually improved by a clinically meaningful amount after a couple of months, compared with 40% in the usual care group. So what the value of the treatments were was it had a clinically meaningful impact on 20% of people. So that's where the number needed to treat of 5 comes in. But so it's not that everybody gets a little effect, it's that most people really, the course of their pain is not affected beyond usual care, whatever that is. And that we know that this is true for a whole range of treatments. What we don't know is whether or not it's generally the same 20% that benefit from everything, or it's a different 20%. So those are complex questions to answer. But and in our studies, we also asked qualitative questions of the people who had received the interventions, mindfulness or whatever, and about 10% of the answers from people that got these indicated something that may be considered a life-changing benefit. So while most people, relatively small fraction benefit, a high fraction of that small fraction actually have a major benefit that may be lasting in some way.
Thank you.
Just 2 comments about the comments that were made. One of the cancer issues.
Push the button, please, Doctor. Yeah, thank you.
Yeah, one on the cancer issue, and we've done one telecare trial of pain and cancer using an optimized analgesic algorithm, not using non-pharmacologic treatments. It was distant telecare. Interestingly enough, not that different of an algorithm that's used in non-cancer patients, except certain cancers may have a specific kind of treatment, occasionally radiation therapy or some, bisphosphonate or something. But most still, it ends up being an optimized, pain treatment. What's interesting is cancer sort of is lumped in that word because a lot of cancer survivors and they end up with chronic pain. That group probably, because cancer gets a pass in opiate guidelines, probably there's a risk of those people getting on chronic opiates and they shouldn't be, And then there's a risk on the other side at end of life because of all of the opiate backlash of some people being deprived and having issues of getting it. So it is interesting, cancer sort of divides into 2 groups now. The only other comment I'll make is I agree with Dan, that so like often the difference is 60% versus 40% in a placebo or other group. I don't actually think it's just the 20%. I think there's that 40% of nonspecific effect that gets discounted in trials but gets optimized in clinical practice. So I think we underestimate the benefit of pain treatments when we build in the nonspecific and therapeutic relationship. Last thing I'd say is that I really think we'll make advances by what particularly this morning was talked about by stepped care, matched care, maybe ratcheting people up earlier if they have high-risk pain rather than going through a stepped approach, starting with self-management and then the safest, simplest approach. But the one thing I'd say is that since this menu has a lot of treatments, all of which have moderate effects, any of these, we got to be careful we don't become paternalistic and say, step 1 is this. You can't go to step 2. Because they're all, patient preference has to play an enormous role. And the final thing I'd say, we found in our trials that it takes about 15 minutes to do a good pain history of prior treatments. In fact, in our trials, that's the biggest benefit. Our nurse care manager took 15 to 20 minutes to say, what have you trialed and what's failed? There is no time for that in practice. In fact, I even came up with the thought of a PATH project, which I didn't try to get funding, pain automated treatment history. Because when you think of all the pharmacologic treatments patients could have tried and all of the non-pharmacologic, and most patients with chronic pain have had it a decade or more, and they've tried many things and it have failed. Now, I know you can say they got a weak dose and all that stuff, but they already come in with a preconception. So I do think being able to take the time to talk about all the things that have failed and then build their preferences in with a relatively equal menu of non-pharmacologic pharmacologic options would go a long way.
Thank you.